This is a lecture that deals with hallucinations and illusions. And in some ways, I think that this seems like a bit of an unusual lecture because it's not, in some ways, the things that we deal with every day. But I think I'm going to try to show you that this is something that comes up a lot more than we would expect. And this is regardless of whether we're an ophthalmologist or an optometrist or any sort of vision specialist, that often patients have complaints that we need to be fine-tuned into what the nature of the complaint is. So we'll just start off with a case that I recently saw. This is a 42-year-old woman, and she's healthy in general, and she, for 2 months or so, had been experiencing these sparkling dots in her vision. And she, ostensibly maybe went to go to see her optometrist and to see maybe her glasses weren't appropriate, but the prescription was fine. And then she went to see a general ophthalmologist about this. And the general ophthalmologist didn't have any sort of findings on the examination, but because of this sparkling nature, there was a concern that maybe this was some sort of retinal pathology that was causing flashes. And so she was referred to a retina specialist who very carefully checked and didn't find any reason for the flashes. At this point, no one really has any idea what's going on. And so now she's referred to maybe see a psychiatrist because there's really no obvious reason for this. And it's thought that this is all in her mind. And finally, she winds up seeing a neuro-ophthalmologist. And we'll come back to her story later in terms of what the outcome was. And this kind of presents the challenge of these sorts of situations because I think particularly as ophthalmologists, we're used to findings on our examination. When someone comes in, we all know that sometimes we can just practice essentially veterinary medicine. We don't really need sometimes to hear what the patient has to say. We can almost certainly 90% of the time just check their eyes and figure out what the problem is and kind of make our treatment plan based on that. And most of the time we might be right. And this presents a problem for us when we have a situation where there's no findings on our examination and the patient has this complaint. And that the unfortunate thing that can happen is that we make an incorrect conclusion, assuming that this patient must be crazy or that the patient's lying. That's a non-organic story. And this is what I hope that we'll avoid after this lecture. So this is what I want to speak about, various types of hallucinations and illusions. And I'm just going to make a disclaimer right now that this is not to cover the whole spectrum of all the phenomena that are out there. I've kind of picked some select ones that I think are more relevant to focus on today. And for people who are interested in reading up on it more, there's a wonderful chapter in this textbook that kind of goes through in much more detail than I'm going to have an opportunity to discuss today, all these sorts of phenomena. Okay, the first thing I just want to clarify that's very important when we deal with these patients to make sure that they're not some sort of psychiatric disease, is to tell you that if, in most cases, if someone, for example, unfortunately is suffering from schizophrenia, and that's the reason that they're having their hallucinations, that there's an important component, that most of the time they'll also have auditory hallucinations. And if you have someone who's just strictly having visual hallucinations, that makes it much less likely that this is a true psychiatric issue and should make you second guess dismissing them as being crazy. The other thing that's very important is the insight that most of these people will come to us and maybe they'll say that they're seeing very unusual things, but they know that they're not real. Whereas someone, again, unfortunately who suffers from schizophrenia can be very convinced that these sorts of things are real. And schizophrenia is just one example. There's unfortunately other sorts of conditions like Alzheimer's that can have similar sorts of psychiatric manifestations here. Okay, so we're going to start off with the first major category, and that's entopic phenomena. So when we talk about entopic, just in terms of the meaning, as medical professionals, just for example, we're all familiar with ectopic pregnancy. And ectopic pregnancy means a pregnancy that's occurring outside of the typical location. And so when we say entopic, we're talking about phenomena that are happening within, the opposite, within the place that they're supposed to be happening and within the eye. And we can divide entopic phenomena up into pathologic and physiologic. And we are, as specialists, are very familiar with the pathologic entopic phenomena. And ironically, it's maybe the physiologic that we're less sometimes familiar with. So in terms of the pathologic phenomena, these are the things that we see very often. Patients with floaters, flashes, halos, that can be caused by disorders of the retina, the vitreous, cataract, sometimes angle closure glaucoma, and I'm not going to spend any time talking about this because this is part of our bread and butter of our profession. Let's talk about more of these physiological manifestations that can occur. And here's a list of 4 ones that I'm going to talk about, and we'll go through them one by one. So the first thing to clarify is just the differentiation between illusions and hallucinations. This is more semantics, but I think you can't give this lecture without just pointing this out, that illusions are a situation where there is some sort of stimulus and the person's misinterpreting the stimulus and just thinking it's something else. And that would be maybe in the case of seeing a visual floater, that there's an actual piece of vitreous in front of their eye, and they're misinterpreting it into thinking it's something other than what it is. There's some sort of dark clouds floating out in space, for example. And then we have hallucinations, and hallucinations are perceptions, visual perceptions that we would have where there's no actual stimulus even provoking it. So here's the first one, this enhanced blue field. And this is a phenomena that you can experience if the sun comes out and the sky clears up today. You can look up to the blue sky, and if you kind of focus on it for long enough, you might see these little white dots moving across your visual field. And you might notice that they're not perfectly spherical, they have a bit of an elongated shape, and you just see them for a couple of seconds and they kind of vanish. And the other interesting thing that you'll see makes sense in a second is that if you're astute enough, you might find that they kind of tend to follow these similar paths as they move around. So what's going on? So it turns out that this is a phenomenon that's due to white blood cells flowing through our retina. And the idea is that, as we know, we have blood vessels that are covering our retina and bringing blood. And the first question that you could ask is, since our photoreceptors are sitting behind those blood vessels, why don't we always see blood rushing through our eye, right? Right now, as I'm looking out at you, there's all sorts of red blood cells that are passing through my retina, and they should be stimulating my photoreceptors, and I should be aware of them. And so I'm sure you're guessing that the obvious answer is that they're filtered out, that we have a visual system that knows how to adapt to this and to take out this aberrations that these red blood cells are causing, and particularly the color. So that the photoreceptors in some way, for example, seem to have some sort of dark adaptation process where they make changes to accommodate for the fact that this, the red cells and the light that's going to pass through them or be reflected will be adapted. The problem is that every so often a white blood cell comes along, and a white blood cell lets all light pass through, and then all of a sudden those photoreceptors receive this kind of unusual excessive stimulation, and that's what is being perceived here. So, and because white blood cells, as they pass through the capillaries are very small, they can't retain their spherical shape, and they become stretched out, and that's why you see these elongated dots. And I'll just throw out a question here, just a quiz question. Why would it be that this phenomena would only be perceived in someone's peripheral vision? It'll never, this is what makes it sometimes tricky to see, it'll never be directly in front of where you're looking, it's always off to the side. Right, exactly. Very good. Because the fovea is avascular, and that means that you can never have a white blood cell floating directly in front of your central vision. It would only be in your peripheral vision. Very good. Okay, so next phenomena, some Purkinje figures. So who here has had an experience where they're examining a patient at the slit lamp and the patient says, "Oh my God, I can see my retinal vessels," or something like that? Raise your hand if you've ever had the experience. Yes, it's happened to me a couple of times. And so this is what's happening, that the patient is experiencing a shadow of their retinal circulation and that they're seeing it. And it's named after a PhD student named Purkinje, who quite a while ago noticed that he was experiencing it and defined this phenomena. And it's actually had use in terms of medical treatment, or at least assessment of patients, that today, when we have a situation where we have an opacified visual access, and we want to know what's going on with the retina and if there's a light potential, we might send the patient for a VP or for ultrasound to assess that. But there's also the possibility of putting light on the patient's eye and asking them, can you see these sorts of images here? And the fact that the patient's able to experience it and see it means that their photoreceptors in the retina is obviously working, and it validates that the patient has a retinal potential, visual potential that might justify surgical intervention. Okay, this is another one called Havier's brush, and this is something where, as you're looking at a white background, particularly if it has a polarization. So LCD screens have polarized filters in it. Some people can experience seeing a phenomena that I'm showing on the left, where you see this kind of hourglass of colored yellow and blue figures intermingling there. And it's thought that it's caused, it's due to the unique configuration of our photoreceptors and our fovea, that they have a way of kind of slicing the white light into various colors depending on the angulation of it. Truthfully, I don't understand the optics enough to appreciate it, but I just wanted to take a poll as you're looking at this white slide here. Does anyone think that they see Haydinger's brush? You can just raise your hand if you're kind of focused on it, and just let me know if it's kind of coming into view. Just keep focusing on it. You might start experiencing something. So not everyone can see Haydinger's brush, and I still can't see anything as I look up there, so don't feel bad if you're not experiencing it as well. So the last phenomena is these flick phosphines. So this is flashes of light that can be generated in our eye. And in terms of the causes, this can be caused by just putting pressure on your eye. And I remember as a resident at Yale, you teaching us about, I think it was RP patients and young people who will just try to generate some sort of visual perception by pushing on their eye, just that they bring the children to some sort of delight to see. Members granula amaurosis, thanks. So this phenomena, so we know that the retina, anytime the retina is stimulated, that the brain will experience light from the stimulation. And so this is something that's relevant sometimes in the retinal pathology, that when the eye is moving around, that the tension, the traction on the retina can cause flashes. And apparently even, I wasn't saying I was aware of, but that when patients accommodate for a long time, that there's a possibility that there can be traction from the ciliary muscles on the retina that can cause phosphines. If anyone's ever experienced that, I'd be happy to hear about it. So these are the physiologic entopic phenomena that people can experience. And sometimes I have had patients who've come in where this was all that was going on at the end of the day. And I think that particularly it's obviously sometimes maybe a type A personality who's a young, healthy person who's become very concerned about the fact that they're seeing things and just needs reassurance that this is a normal phenomenon. So now we're going to a different extreme. We're going from, in general, healthy eyes, where everything's fine with the person, and they're just experiencing something that's fine to experience, to place situations where there's really a problem. And this is the Charles-Bonnet syndrome. So Charles Bonnet. So just in terms of some trivia, so Charles Bonnet was this naturalist and a philosopher, and I'm sure we've all learned in our medical training that the art of phyllotaxy, and this is the arrangement of leaves on plants, this is very important to know about, that there's two major arrangements that he lets the world know about, that they can either be arranged in an opposite way or an alternate way. And this changed my life, of course, finding out about this. And I think it might be the most important point of the lecture here to take away. Okay. So anyway, that's basically what Charles Bonnet did for the world, and I think that the Charles Bonnet syndrome might be a little bit more important, just in my perspective. So what's Charles Bonnet's story with vision? So he had a grandfather, and the grandfather had dense cataracts that, of course, at that time were problematic and couldn't easily be taken out. And his grandfather started experiencing these very vivid hallucinations. And I guess he knew his grandfather well enough to know that the man was not crazy, and put two and two together that maybe the lack of vision coming into his grandfather's eyes was allowing him to have these hallucinations that, again, were not psychiatric hallucinations. And so he got the syndrome named after him. And so the important thing here to point out is that this is a situation where anytime there's visual loss, and it can be minor or partial, and it can be anywhere along the visual system. So just the other day, one of our cornea specialists was telling me a story about a patient who, after many, I think, failed attempts for PKP, started complaining about these unusual experiences of seeing hallucinations, very vivid hallucinations. And it's pretty clear that this is a case of Charles Bonnet. So again, it doesn't matter whether it's something that happened in the brain or in the retina from something like AMD, or in the cornea, or even apparently patients who don't have proper glasses, if it's enough of a discrepancy and they're really walking around with blurry vision, can potentially, according to literature, have unusual hallucinations. I haven't experienced that, but we just need to be aware of this phenomena. And again, it can be apparently even minor vision loss. And one of the things that I was shocked to see was a report where there was a patient who had pseudotumor cerebri and just had blind spot enlargement. And that doesn't usually affect your visual field very much. And that within that defective blind spot, the person started experiencing hallucinations. So pretty shocking. And of course, what will happen is when it's partial, that the idea is that when the brain is not getting visual inputs, it's going to start generating images. And the layman's way that I'll explain to patients is that when they go to sleep, of course, and their eyes are closed and the eyes are not providing any visual stimulation to the brain, what does the brain do? The brain starts generating its images of its own, and maybe that's what dreams are. And of course, it's certainly not that simple. But I think that that's in some ways what is going on here, so that there are people out there who kind of have a partial situation where, particularly when they're in dark settings and their visual system's not giving them enough of a picture, then they're going to start having this experience out there. And when they're in bright lights and their visual inputs increase, then it'll be overridden. And that becomes relevant in terms of managing these patients. And the real, probably more scientific way to relate to this phenomena is called a release phenomenon. Again, the brain is kind of releasing visual images that it's creating that are probably normally suppressed due to the absence of a visual syndrome. And this is probably the more appropriate term now to call these release phenomena rather than Charles Bonnet, but history prevails. One, again, just interesting anecdote was that apparently there's been patients who have had, for example, homonymous hemianopia, where instead of coming in and telling the doctors that I'm not able to see over here, everything's black, they were saying that I'm seeing unusual things going on in this visual field. On everything on my left, I'm seeing clowns and dinosaurs walking around, and that because it was discretely in their left visual field, that led to the suspicion that they had a homonymous hemianopia. They lost vision over there, and already they were having Charles Bonnet phenomena, and that was what was going on. Okay. So in terms of management for Charles Bonnet, so far and away, the most important thing to do is reassure the patient that this is expected. And it's obviously in an ideal world, we would probably have the time to sit down with every patient who's had vision loss and prevent or prophylactically sit down with them and explain to them that they might have this phenomena happening, and that if it does happen, that they should be reassured that they're not crazy. We talked about lifestyle modifications, that they basically just increase the amount of light, and that their family needs to be aware that they have to pay extra energy in the house for increased lighting, and that can make a big difference for the patient as well. Unfortunately, medications, there's really no good medications that can help for patients who find it debilitating, and psychotherapy is sometimes needed to help them manage when it just becomes debilitating, and there are patients who, despite everything, are completely debilitated by this. Sometimes if you don't understand, I don't think science understands why some patients have it and other patients don't. We also don't understand why some patients maybe will have it for a period of 3 months and then it goes away, and other people will just have it for the rest of their life and not go. Okay, next topic, so seizures. So probably not surprising that a seizure can generate hallucinations, and we're just going to focus on this briefly, so that the main places in the brain that we would be dealing with are the occipital lobe and the temporal lobes. So the occipital lobe makes sense, that's where vision is generated in the brain, and here what can be a little tricky is that sometimes it can be almost an isolated phenomena of the hallucinations. So when we think about someone having a dramatic seizure, we're thinking about their body shaking and they're losing consciousness and also they're confused. But here, when it's happening just focally in the occipital lobe, it can just be a visual experience that can be tricky for physicians to identify. Because it's happening in the occipital lobe, and if it's particularly happening just in the V1 area, the images that the patient sees are very simple sorts of things, just lights and flashes, because the development of more complex visual imagery is happening in higher order visual areas. Sometimes there apparently can be associated features with this, where the eyes are blinking or moving in unusual ways, but not always. When it happens in the temporal lobe, that's the place that I think more classically is usually involved with epilepsy. However, their visual hallucinations are actually a minority of the phenomena. Here, when they do happen, they'll be much more complex, with very sort of interesting images that the patient will be seeing. It's classically associated with some other phenomena that often can trigger the physician to know that that's happening. Okay, migraine. So migraine is a big one out there that I see a lot of, and I think that your as medical professionals will definitely see patients that will come to you with migraine, and we need to know what migraine is and some of its variations, and I'm going to spend a little bit more time talking about this now. And the problem in some ways is that there's this understanding of what a classic migraine is. So here's a story of a classic migraine. So someone gets, first of all, some sort of aura, and in terms of vision, it's something funny is going on with their vision, and it lasts maybe for up to an hour, typically about half an hour. And this experience, whatever it is then followed by a headache. And it's typically a headache that's one-sided. The patient will often have a pulsatile, like complaints of pain. And then there's associated features with it that the patient will have sensitivity to light, nauseous, sensitivity to sound. And when a doctor hears this sort of story, and it's pretty clear that this is migraine, the problem is, just in terms of its how the migraine works, that it's often set off in one part of the brain, and through this phenomenon that we're not going to get into called spreading cortical depression, it spreads to other parts of the brain, so that when it in here, where it starts in the occipital cortex, it'll start in one particular place. The patient will experience a visual hallucination in one particular place, and as it spreads out through the brain and through the occipital cortex, all of a sudden that hallucination will expand over the period of that half an hour to occupy more and more of the visual space. The problem is that there's a lot of people who have migraines that are not classic, and that's where they fall between the cracks. And one particular form is something called an acephalgic migraine, which means that the patient doesn't get the headache. And this is very hard for patients to understand, and sometimes clinicians, that a migraine can happen without the headache at all. And so in these cases, it's known that it's more common in men. And obviously, when this sort of experience happens, it becomes alarming that maybe the patient's had a transient ischemic attack. And so this brings me to another case. So this was a 25-year-old male. He was a graduate student. He was working in his lab one day, and all of a sudden, something started going wrong with his vision, and he experienced this very exceptional episode of not being able to see clearly for 30 minutes. He was surrounded by other doctors in the lab, and when he told them about it, they became very alarmed, but they didn't understand what was going on. And so eventually he was kind of referred to a general doctor who referred him for a cardiovascular workup out of a concern that he experienced a TIA. That was completely negative, and then he was referred for an ophthalmologist. He went to an ophthalmologist who basically told him, I have no idea what's wrong with you, everything's fine on your examination, and probably thought he was crazy. And so he was left without any explanation, very frustrated. And later on, he went on to become a neuro-ophthalmologist in life. And when he learned about migraines, he understood that what he had all those years before was a migraine. And when he learned about it more, he realized that there was a family history, and that's very relevant with migraines. And he understood why he had motion sickness as a child. So for those of you who have children, it doesn't necessarily mean that they're going to have migraines, but motion sickness is very associated with migraines. And this is why if we ever go on a TO, I need to sit at the front of the bus. I'm just telling you right away. Okay, I'm going to get the front seat. So in terms of the hallucinations, there are a lot of different visual experiences that the patients can have, and we're just going to spend some time talking about some of the more prominent ones. Okay, so the first thing is that the patient sometimes will complain that they start off by seeing some sort of jagged area in space. And this is something that's been called a fortification line. And just another historical anecdote here. So this comes from the fact that in medieval times, certain towns would build their fortress in a star-like formation, and this apparently created a strategic advantage. It was more difficult to invade and capture the town if it was built in this way rather than traditional spherical form. And so someone, I guess, who was a migraine expert and a history nerd decided to call these jagged lines fortification lines. They will often kind of sparkle or pulse in space, and sometimes the area within the arc is faded out. And so that the patient will say that there's this area that's kind of flashing, and within that, they can't see properly. And this is a negative phenomena, and this kind of together creates something called a scintillating scotoma. And this is a depiction that an artist drew who has migraines of what she was experiencing, and she says it was even as impressive as this looks, she says it doesn't even compare to what she was experiencing at the time. Sometimes the hallucinations are just very, very simple hallucinations that people experience, just something as simple as sparkles. And sometimes they're much more complex hallucinations, so a person can envision that they're seeing people or persons or animals. This is an animal that thinks it's a person. This is my dog, who thinks that she's a better driver than me, and she probably is. So the other thing that people can have is they can have polyopia. So we're familiar with diplopia, but polyopia is just a general term for seeing multiple images. And so if this patient comes into an eye doctor and says that they're having these experiences, then someone's going to think that maybe they have a strabismus. Well, they don't have a strabismus. They might think that it's an optical issue, and it's not an optical issue. And particularly, just a question for the residents, if someone has a diplopia that's cerebral and it's not monocular, or how do you differentiate monocular versus not monocular diplopia?
Close the eye.
Okay, close one eye. Pinhole, right? So if it's an optical monocular diplopia, it should resolve or get a lot better when you give the patient a pinhole. And if it doesn't, then you got to be thinking that it's something else. And in terms of maybe more of a cerebral origin. Very rare. Another thing that patients can experience is a palinopsia, where they see kind of a persistence of images or an after image. And this is another exceptional sort of description of something called the Alice in Wonderland syndrome. So we'll come back to Lewis Carroll in a second, who's the author. So in this case, patients have these very vivid descriptions of just all of a sudden everything feels different in terms of their relation to the rest of the world, that they feel unbelievably small compared to everything else, or unbelievably large. And it can affect their whole body, or sometimes this is a patient who just described that just their ear felt unbelievably large for a period of an hour, that it was just completely ballooning out. And it's thought that this author, who kind of, I think was a neurologist who saw patients like this and had read Alice in Wonderland, looked into it more, and there's a thought that the author, Lewis Carroll, maybe had migraines, and that these migraines and these unusual hallucinations that he had inspired him to write his story. Okay, another even more unusual experience is something called otoscopy, and this is a situation where the patient has an out-of-body experience and actually during their migraine sees themselves from above, for example, which sounds pretty outrageous. And this is even more dramatic. Not only did this person see themselves from above, but they were lying on a railroad track about to get run over. So it can be pretty dramatic. And we can understand how obviously someone who has this sort of description is going to very quickly be sent to a psychiatrist. And maybe that's the first thing that they should be done at first when these sorts of very concerning sort of hallucinations. But again, all these things just can be migraine sometimes. So we've kind of gone through the ones above. The ones that below are something that we're more familiar with as ophthalmologists and optometrists, so I'm not really going to focus on those, but we understand that patients can sometimes see images to be too small, too large, distorted, or negative phenomena, where it's just kind of blackened out. And we just went through with the lecture, with the residents, a series of lectures on approach to negative phenomena and transient vision loss. The other thing that was kind of alluded to is that when we have a patient who's describing this, it should be a binocular phenomena. And again, how do we confirm that? What do we ask the patient to confirm it's a binocular phenomena? Right, so it's very important to always ask the patient when someone comes in and says something went wrong with my vision, did you check? Was it just your right eye? Was it your left eye? Is it both eyes? And when it's clearly both eyes, then that can be more consistent with the fact that it's a migraine, and that makes sense, right? Because if something's going on in this part of the brain, we know that how the visual pathways work and the optic radiations, and that's going to track back to places in the retina, and that's going to correspond to an image that they think is being generated someplace in space when that's actually just happening inside their brain. And as this focus expands because of this cortical spreading depression, the image of what they see is going to gradually expand over the half an hour. And again, it's one of the features that the patient will often describe, that it started off in one place and got larger and larger and larger. And again, all this lasted for usually about a half an hour. So, and usually if they're astute enough, they'll confirm that it's binocular. Here's the problem. If it happens way out here, very, very peripherally, what's going to happen? So here, the image, or an image that's that far peripheral, can stimulate the retina, the nasal retina on the ipsilateral side, but it's so far peripheral that it's going to miss the other eye. It can't get there. And if you want, if you don't mind, just take a second right now and hold your finger in front of your eyes, and keep closing your eyes as you move it out to the side. Go back and forth, and eventually you're going to come to a place where it's going to be so far peripheral you're just seeing it on the same side. You can't see it in the other eye. Now maybe that's a little bit because of your nose, and that some of it's being blocked by your nose, but it's more complex than that. You actually don't have a temporal retina that's as developed as a nasal retina to capture the images, and that results in the fact that there are places, situations when it's very peripheral where it's just going to be perceived as a monocular phenomenon. So again, there are, in the outside zones of our peripheral vision, about 30 degrees, we have this place that's just monocular, and this is a phenomenon called a temporal crescent. For people who do, for example, Goldman visual fields, they're aware of it. And this means that there are places inside the brain, and if a person had a migraine where we're centered in these areas, which are more anterior in the occipital cortex, then what they can have is a truly monocular phenomenon. So I remember, again, just thankfully I don't have migraines very often, but the last time I had a migraine about a year ago, I was shocked because I knew I was experiencing a migraine. Something unusual was happening, but it defied the rule that I always asked my patients, is it monocular or binocular? And I would become frustrated with them when they couldn't figure it out. And I kept closing my eyes, and I thought, oh, this is just a monocular phenomenon. What's going on? And then I remembered, of course, the idea of the temporal crescent. And so it is possible that the patient will come in and talk about an episode and they'll promise you it was monocular. And again, if it's far enough in their periphery, that can be the case. Okay. The last thing in terms of migraine is that we usually think about migraine as being attacks. The patient gets an attack, and then they're fine. And then they get an attack maybe a week later, and then they're fine. Unfortunately, some people can have a phenomenon called persistent visual phenomena, where even between the attacks, their visual system is out of whack, and they're seeing things such as dots and snow and all sorts of unusual things that are just there all the time. And that could be more challenging in terms of treatment. So in terms of the management in general for migraines, obviously migraine is a neurological disorder, and a neurologist should be involved. It's important to know, and this was just a topic that Nomi brought up before we went in here today, that there are mimickers. And this was the one that Nomi was telling me about, a patient who was having hallucinations, and maybe it could have been dismissed as being a migraine. In this case, because she was appropriately investigated, it was an arteriovenous malformation. So certainly the vast majority of people who have migraines are not going to have some sort of mass in their brain that's causing it, but there should be a low threshold for considering those investigations. And this is why, at least when I'm seeing these patients, I want to have a low threshold for sending for neuroimaging, particularly if it's an adult who's never had any sort of, there's no family history, there's nothing that, again, is a clear lock for migraines. And if it's the first time they're having these experiences, then that's concerning enough, I think, to send for MRI. And the other thing, of course, to remember is that because migraine occurs on usually one side of the brain, and usually you'll have a visual experience on the opposite side. So I'll sometimes ask the patient, does it always happen if your visual hallucinations are always on the same side of the world? And if they always say, yeah, it's always on my left, then that makes me very concerned about the possibility there could be a structural reason. Certainly they need neuroimaging for that. Okay, so now we're going to go into, from migraine, a very well-known diagnosis, to a much more new diagnosis that's in the world of neuro-ophthalmologists right now, called visual snow syndrome. So this is a situation, we've alluded to this before. These are people who say that something's wrong with their vision, and they have a lot of trouble describing what's wrong. And it turns out that what they're experiencing is that they see the world as if snow was falling down through their visual picture, or static, like on the old televisions when there wasn't a signal, that you would see static. And this is what these people are seeing all the time. And it can drive them crazy. And even during my fellowship a couple of years ago, we would have patients who would come in, and they'd be healthy people, and usually it was kind of one of these complaints that we weren't so comfortable with, because we knew that probably they were fine, we knew it was probably some sort of migraine episode, but we didn't really have a way of defining what they were experiencing. And now, particularly, a very nice paper has kind of come out and consolidated the information on this in the Journal of Neuro-Ophthalmology this year about an actual syndrome, and that when you if you go into more depth and ask these patients about other sorts of phenomena, all of a sudden they might note that they're experiencing things that they haven't really been thinking about before. And so these patients will sometimes talk about palinopsia, where they will say that they're looking at the place. And I've had 3 patients, I think, within the last year that have told me about this experience where, along with these visual dots that they're seeing, that they'll say, I'm looking over here and I'm looking at this image, and I kind of shift my gaze over somewhere else, and still the edge of the desk that I was looking at is persisting over there. It's only for a couple of seconds, and sometimes it takes them a while to become aware of this. That they can have a lot of sensitivity to light, they're intolerant, they sometimes have trouble seeing in the dark, and also that they can experience tinnitus. So it's not just a visual phenomena, it's some sort of sensory phenomena with the hearing unusual sounds. So what's going on here? So it's not clear. It is clear that these people are healthy. If you do an MRI on them, you're not going to find sort of any disease. And it's because one of the most important things to reassure the patient that they are going to be fine. It's probably some sort of impaired processing. And again, when I'm explaining to patients, the example that I'll give is, we know about ADHD, and that a child that has ADHD have a good life, but that there's maybe something quirky about the way that the brain is processing information, and that maybe here these people are having a bit of impaired processing, that in terms of the stimuli that are coming in, that there's a lowering of kind of the filtering threshold, and that their brain is being kind of overloaded with all sorts of stimuli that are out there that the brain normally is able to filter out that we don't think about. And so again, the example that I would give is that as we're sitting here right now, you're sitting on your chairs, and if you think about your chairs, you can maybe think about your legs touching the chairs and contacting the floor, and maybe you can now hear the air conditioner that's on in the room, and all sorts of things that have been there and have been sending information. Those neurons are always sending information to your brain, but your brain is able to filter that out so that you don't have to think about that, and you're able to focus on what you need to. But if you have a situation where that filtering is not working so well for whatever reason, then all of a sudden you're overloaded with all these stimuli that are true stimuli that are out there, but you're just hearing that. For example, in terms of pulsatile tinnitus is generated from what? What's causing a pulsatile tinnitus? Your pulse, right? But there's actually blood flowing through your ears, and all of a sudden you're hearing it when normally that's censored out. And so in terms of the processing, there's been various studies that have shown maybe different changes in metabolism in terms of various places in the brain like the lingual gyrus, which is associated with vision. And what's an important structure resonance that's very important for filtering out sensory stimulation? The thalamus, right? So we just had a lecture on Monday about this, and just the importance that we gave the thalamus is basically the part of your brain that's filtering out the fact that you're sitting on the chair, and hopefully you're focusing on the lecture, I hope, and not thinking about the chair or the air conditioner at this point. And the idea that the thalamus we can think of, we just mentioned, is kind of this place in the brain is kind of like the secretary. That all this information that's coming in, before it goes up to the cerebral cortex, the bosses, it kind of gets filtered out there, and the secretary decides what's going to go up to the cerebral cortex and what we don't bother the cerebral cortex with, and that's what it's doing there. And that maybe there might be some sort of unusual change in terms of how the thalamus is functioning, for example. But these patients are healthy, and the most important thing to do is to reassure them that this is not going to be a dangerous thing and that they're going to be fine. And in terms of treatment, reassurance is often enough. If they're really having trouble and struggling, then there's been studies that have been shown that various tinted or colored lenses can be very, very helpful in terms of somehow maybe reducing the amount of visual stimulation that they have, and that it can be a very, very helpful thing for them to function. And in situations where that's not helpful, there are various medications that have been shown to be effective. So one of them is acetazolamide, which I was happy to see that acetazolamide was on the list, because as a neuro-ophthalmologist, we're very comfortable with acetazolamide. The other one is lamotrigine, and that's something that's been more used for epilepsy, and it makes sense, right? When you have someone who has epilepsy, you're having kind of unusual, excessive brain activity, which is maybe what's happening here, and so that we understand why this drug can be very helpful. And so now in terms of the spectrum of patients, I think I have now like 5 or 6 active visual snow syndrome patients. In terms of the management, they're in the spectrum here of all these different strategies. And when we go back to the case that I started off our lecture with, this is what this woman had, who'd gone through all these specialists. She had a very, very clear case of visual snow syndrome, But it wasn't until I started asking her, by the way, do you ever have this, that she was almost shocked that she wasn't able to articulate it, but all of a sudden she realized that she was having all these other very, very specific experiences that went along with a very clear diagnosis of what she was experiencing. And for her at that point, she walked out of the room and just said, thank you, I now can be reassured that I'm healthy again. And she sent me an email later just saying how much this had concerned her, that there was something going on. And she told me later that she had some sort of, unfortunately, sick relative who had some sort of brain disorder, and she was worried that she was developing a brain disorder. And just knowing that this was a benign condition, that was all that she needed, and she could go back to her life. Other patients who have function well with the colored lenses, and I have one patient that we're just starting treatment with lamotrigine now, who's just been completely debilitated by her condition. Okay, our last topic before we wrap up is drugs. So in terms of drugs, we have the medical drugs and the recreational drugs. And we'll start off with the medical drugs. And we're not going to go through every hallucination that's associated with every drug on the shelves of the pharmacy, but we'll just go through some of the examples of the top drugs here. So here's a picture of Vincent van Gogh, and the story with him is that he, as we know, was unfortunately not a very well individual. He had a lot of illnesses, and one of them was believed that he had maybe some sort of epileptic disorder. And this is a picture that he painted of his doctor. And the doctor is holding in his hand the medicine. It was a plant, and the plant is called a foxglove plant. And the foxglove plant had some sort of medicinal value. But what the active ingredient is something called digoxin. And digoxin is something that's now much more commonly used by heart specialists in terms of regulating the heart rhythm, but it was thought at that time that maybe it would be helpful with the brain. And the side effect of digoxin is that because of some sort of toxicity that it can have in the retina, the patient can actually start experiencing yellow vision. And there's known to be a phase of Van Gogh's life where his paintings, it was called the yellow phase, where a lot of his notable paintings that came out during a period all had this very excessive yellow presence in it, and it's hypothesized that this is what was going on with him at that time. Now, so if your patient's complaining to you about seeing yellow, then that's maybe a tip-off. You need to ask them about the digoxin, or whether they have a doctor from 200 years ago who was giving them some sort of unusual plant. Now, if your patient's saying that their houses that they're seeing are unusually blue, there's another sort of condition or another drug you need to ask about. Yeah, Viagra, right? Sildenafil. Okay. Now, there are certain patients who, if they've seen a blue house, that doesn't mean that they're taking Viagra. This, for example, is something called the Blue House that's in South Korea. This is the official residence of the president of South Korea, so please do not insult the president of South Korea. Okay, so in terms of just the last drug I want to speak about is levodopa. So levodopa is a drug that's given for what condition? For Parkinson's, right? And the problem is that, so people who have Parkinson's benefit from levodopa, but levodopa causes hallucinations, but the problem is that Parkinson's can cause hallucinations as well. And so this is sometimes a situation where the neurologist will be struggling with a patient who's really debilitated by unusual hallucinations, and the neurologist is trying to figure out, is it the levodopa that's causing it? And we need to lower the amount of levodopa, but then if it's being caused by the Parkinson's, then the hallucinations are going to get even worse. So one of the things I didn't focus on this lecture is neurodegenerative diseases like Parkinson's and Alzheimer's that can be associated again with hallucinations. Okay, recreational drugs. So this person is experiencing a sensation of bugs crawling their skin. What drug? Cocaine. Very good. Cocaine. And this is a person who is seeing pink elephants, supposedly. What's their drug? A good guess. So it's not that they're taking a drug, it's that they stopped the drug. So for whatever reason, people who stop using alcohol have this very stereotypical experience of seeing pink elephants. And as I was just going through the presentation with my wife yesterday, she told me a story that there was this lounge in the Catskills in America called the Pink Elephant Lounge that she remembers as a child that she would vacation there, and that she was never allowed into this place called the Pink Elephant Lounge, and she'd always wondered what it was, and as a child, and now she understands that it was a bar. It's kind of obviously an ironic name for a bar to give when you're talking about stopping drinking alcohol, but I guess that they were very pro safe choice. LSD definitely can cause hallucinations, and again, this is just one of these situations where we're just seeing these very stereotypical classic descriptions that for whatever reason people have. And for whatever reason, supposedly, people who take LSD, a huge amount of them have this experience of seeing the devil's face freely floating on their friend's body. And it's just this very characteristic experience that people who have taken LSD have experienced, or this other experience of seeing their friends or their family members just rapidly age right in front of their eyes. Okay, so we're at the end of the material that I want to present to you, so I just want to just review the major points that I'd like you to take home. Probably the most important point, I'd like you to remember what phyllotaxy is, and to remember that the arrangement of plants can be opposite or alternate. To remember that the president of South Korea lives in a house called the Blue House, and to remember to never touch this drug this plant called foxglove. Maybe more minor points for the vision specialists in here are just to remember that we have this group of unusual hallucinations that are out there that some of our patients are definitely going to be experiencing, such as the Charles Bonnet phenomena. And that when we have a situation when someone comes in and tells us that they're having unusual visual experiences and there's no findings, we have to avoid the mistake coming to these incorrect conclusions that they're crazy or that they're lying, and that we have to take a moment to sit and talk to them more and explore the possibility that maybe this is what they have, one of these sorts of category of conditions. So good luck and thank you.